Morning all. So now we'll be moving from risk predictive models to the treatment modality. So role of radiation therapy in CA pancreas. Pancreas is the 15th most common cause of cancer globally, with an incidence ASR of 4.9 per lakh population. For the purpose of treatment modality, we divide the patient as having an operable disease or borderline resectable, locally advanced or metastatic disease at the time of presentation. For the resection criteria, the tumor location and its relationship with the arterial and the venous system has to be taken care of. So the arteries which are involved is celiac artery, superior mesenteric artery and the common hepatic artery, and the venous system is superior mesenteric vein and portal vein. Accordingly, we divide it as resectable, borderline resectable and unresectable disease. And so for the resectable disease, the treatment is surgery and followed by adjuvant therapy. So what type of adjuvant therapy is required and why it is required is the question. So if we talk about the recurrence pattern post-curative resection, in this study by Andrew et al. And another meta-analysis, they found that there is loco-regional recurrence in about 10 to 25% of the patients, whereas the simultaneously loco-regional and distant metastasis is there in about 44 to 50% of the patients. Therefore, with the very high chances of recurrences, these patients required some form of adjuvant therapy. Some of the trials of adjuvant therapy is in late 90s, the GITSG trial and URTC trial was there, in which observations was compared with chemoradiation therapy. There was improvement in the overall survival, but the fallacies was the split course of radiation therapy was used in this trial. Further came the SPAC1 trial, in which chemotherapy was compared with chemoradiation therapy. But here in this trial, there was a detrimental effect of radiation therapy because of the poor radiation therapy techniques used. And therefore, the chemotherapy becomes the treatment of choice as an adjuvant therapy in CONCO1, SPAC4 and PRODIGE24 trials, suggesting that adjuvant chemotherapy has a role in improving overall survival and disease-free survival. In early 20s, there was another trial, RTOG 9704. If we compare CONCO1 with RTOG 9704, then the median overall survival is comparable in between the two studies. But we can easily find that the patients who underwent chemoradiation therapy, they had better local control of the disease, suggesting that the local recurrence likely is because of the patients who received chemoradiation therapy. In the secondary analysis of the SPAC4 randomized adjuvant chemotherapy trial, in which gemcitabine was compared with gemcitabine, again, there was an overall survival of 29 months, but local recurrence was about in 50% of the patients. Also, they have found that the patients with local recurrence had poor overall survival on long term as compared to distant metastasis. Kim et al. Has found the factors which are responsible for early loco-regional failure as CA 19.9 more than 200, node positive disease, PNI positive and margin positive disease, to conclude that patients with risk factor could be benefited with local adjuvant treatment in addition to adjuvant chemotherapy. And therefore, RTOG came up with RTOG 0848 trial for 1527 patients. It is recently in ESCO 24. And this gemcitabine, adjuvant chemotherapy with gemcitabine with or without erlotinib was compared with sequential radiation therapy with gemcitabine. So the long-term survival, there was similar overall survival in the two groups, but the disease-free survival was better in the patients who received chemoradiation therapy as compared to chemotherapy alone. Further, on subgroup analysis, they have found that the patient with node-negative patient, they had benefited with the addition of sequential radiation therapy in terms of overall survival and disease-free survival. Another SEER database review in which surgery with chemotherapy was compared with surgery, radiation, and chemotherapy. In a propensity score matching with 1150 patients in each arm, the 5-year overall survival is 19% versus 24%. Also, they have found that the patients with pancreatic had T3, T4 disease, adenocarcinoma, or CA pancreas had with infiltrating ductal carcinoma with T3 disease and node positive disease, they had better overall survival when radiation therapy was added as an adjuvant treatment. So what are the areas where there is local recurrences? So in this trial, Bardalokia et al. Presented Red Journal in 2013, the authors mapped the recurrences site, and they found that 90% of the recurrences were within the close proximity of the superior mesenteric artery and celiac artery. And therefore, the adjuvant radiation therapy standard field should encompass the tumor bed, anastomotic site, and the regional lymph node areas. So this is the color wash of one of our patient with CA head of pancreas, post-Whipple with higher risk factors like T3 and 2 disease, node positive, LVI positive, PNI positive. So the patient has received 4 cycles of GEM-CAPE followed by adjuvant chemotherapy, adjuvant radiation therapy to a dose of 50.4 gray in 28 fraction at the rate of 1.8 gray per fraction with concurrent capecitabine. Now, the new adjuvant or the radical radiation therapy is given in cases of borderline resectable and locally advanced cancers, and the rationale is it increases the chances of R0 resection, reduce loco-regional recurrences, and early delivery of the systemic therapy for radiographically occult metastatic disease. New adjuvant therapy has been divided in borderline resectable CA pancreas and locally advanced CA pancreas. In borderline resectable CA pancreas, in this trial by NACT IMRT by Musai et al., it's a single arm study with 49 patients were enrolled, out of which 37 underwent laparotomy and 29 underwent pancreatectomy. The R0 resection was in 27 patients, that is 93% of the patients, with a median overall survival of 35 months. Again, they have found that the post radiation therapy and surgery, the local recurrence-free survival at 5 years is 80%, while the metastatic disease-free survival was around 30%. Pre-OPANC trial is another trial for the resectable and borderline resectable CA pancreas. So in this, 248 patients were assigned, but finally the chemoradiation therapy was given in 91 patients, whereas the upfront surgery in 128 patients. So according to the intention to treat analysis, there was a benefit of 13% RO resection in patient who received chemoradiation therapy as compared to chemotherapy alone. Whereas post-op CA pancreas proven histopathology patients, they have found that the R0 resection is 72% in neoadjuvant CT-RT arm as compared to 43% in patients who were assigned to upfront surgery. The 5-year overall survival in the two group is 20.5% versus 6.5%, which was statistically significant. And similarly, the disease-free survival and loco-regional failure-free survival. On subgroup analysis, they have found that the patient with resectable CA pancreas, there is not statistically significant differences between the neoadjuvant RT arm versus chemotherapy arm. But in the patient with borderline resectable, there is an advantage of using concurrent neoadjuvant concurrent chemoradiation therapy with a hazard ratio of 0.65. LAP7 is for locally advanced CA pancreas. It's a single arm trial in which 4 cycles of gemcitabine with or without erlotinib was given as an induction therapy followed by radiation therapy. So in this study, there was not much benefit in the overall survival and the disease-free survival. But yes, there was a significant local control benefit after chemoradiation therapy versus chemo, with the local regional progression was 32% in CT-RT arm as compared to 46% in the chemotherapy alone arm. CONCO 7 is a randomized phase 3 trial. The full paper is not published yet. It was presented in ASCO 22, and they have again divided the patient with induction chemotherapy versus induction chemotherapy followed by chemoradiation therapy. And they have found that the R0 resection is 18% in the CT arm as compared to 25% in the chemoradiation therapy arm. Although on the long-term basis, there was not much differences in the overall survival and the progression-free survival, but the patient who underwent surgery, on subgroup analysis, it has been found that the patient who underwent surgery had a 5-year overall survival of 24% as compared to 12% in the patient who do not received radiation therapy. So there is a benefit of using radiation therapy in local control and progression-free survival on long term. Gabbard-Nack study, it is presented in ESCO 24. Paper is not out yet. In this, 2 arms were compared: the new adjuvant nab-paclitaxel with gemcitabine versus new adjuvant CT-RT with S1, with 56 patients in each group. And this overall survival, the median overall survival was not much. There's not much difference in between the median overall survival, but the curves have started separating after 18 months, suggesting that in the long-term analysis and long-term follow-up, there will be some role of chemoradiation therapy in such group of patients. Similarly, the progression-free survival, the curves are separated after 1 year, and the long-term results are awaited. The R0 resection rate did not differ between the 2 groups, but the pathological response rate was twice in group B as compared to group A. That is, in concurrent chemoradiation arm, it is 30.4% as compared to 14% in group A. So this is a color wash of one of our patients who has received the radical radiation therapy in an advanced advanced CA pancreas. Post chemotherapy, we have given a radiation of 52.5 gray in 25 fraction to the major bulk of the tumor, and the elective volume is treated to a dose of 45 gray in 25 fractions. Now the techniques of radiation therapy started from 3D CRT to IMRT and SBRT. As you can see, in the earlier techniques, there is more spillage of radiation to the surrounding organs, and with newer techniques like moving from IMRT to SBRT, there is more conformal radiation therapy with minimum side effects and minimum doses to the organ at risk. So the SBRT is radiation therapy in which very high doses of radiation is given in 5 to 8 fractions, resulting in high BED, more conformal radiation, and high rate of R0 resection. LAB-C trial is a study in which induction chemotherapy was followed by SBRT in a group of patients with locally advanced CA pancreas. Here, the total patients enrolled were 50, out of which 39 has received SBRT and 7 underwent surgery for the pancreas. The 3 years overall survival in the entire group was 10%. The median overall survival was 13 months for the entire group, whereas the median overall survival is 5 months in the patient who has not received SBRT, that is these 11 patients, as compared to the 18 months in the patient who has received radiation therapy. Further, if we divide the patient in whether operated or not, so post SBRT, 7 patients who were operated, the median overall survival, the 3 years overall survival was 43% as compared to 6.5% in the unresected group. That is, it means that in all the patients, if feasible, then induction chemo followed by radiation followed by surgery should be performed to increase the overall survival and local control. Now, in this paper by Hill et al., 155 patients were assigned for the chemo followed by SBRT, but 66% of the patient underwent surgery, and out of this 155, 33% still had either locoregional or synchronous failure at the local site and the distant metastasis. So there is need to improve our radiation therapy technique so as to control the local, for the local control of the disease. This local control can be done by various methods. One is by using SIP, simultaneously integrated boost or protection. In this, a very high dose of radiation is given to the core of the tumor, whereas the organ at risk, which is in close proximity to the tumor, like duodenum, stomach, colon, and jejunum, here we can prescribe a lower dose. So the authors have suggested that the degree of tumor coverage did not correlate with the outcome, suggesting that the dose escalation to the core of the tumor can result in better local control. The second modality is by using fiducial markers. So we can easily put endoscopically guided fiducial markers, the gold anchors or the vesicoil MR markers, in the close proximity with the tumor, so that these gold markers can be tracked during radiation therapy, and we can deliver very high doses to the tumor itself. And these gold markers or these fiducial markers can be seen during the CBCT and during the treatment time. Our main issue of giving very high doses of the radiation therapy to the tumor is the organ at risk. So we need to prevent the doses to the organ at risk like duodenum. So to prevent that, if we can put some hydrogel in between the duodenum or the organ at risk and the pancreas. So in this study, they have injected hydrogel in the endoscopically guided in the pancreatico-duodenal groove. So around 3 cc of the hydrogel is injected, resulting in the space of around 7 millimeter, ranging from 5 to 1.2 centimeter in between the duodenum and the pancreas, so that we can push very high doses to the tumor and at the same time prevent the toxicity of to the organ at risk. So these are the way where we can give very high doses to the tumor and resulting in good local control. Adaptive replanning in locally advanced CA pancreas, MRI guided, is another way of giving high doses. So in this, on the couch itself during treatment, we can see the scans and find the changes in the volume of the tumor as well as the organ at risk, and accordingly recontour the patients, predict the doses, and re-optimize and treat the patients. So this is another way of giving high doses. And in this paper, they have found that with the adaptive radiation therapy planning, the 1-year local control can be achieved up to 88%. Proton and carbon ion radiation therapy, newer radiation therapy techniques works on the principle of Bragg's peak. That is, when the dose is delivered, the dose deposition rate is lower in the early part and it increases at the end of its pathway. So in the proton and carbon ion radiation therapy technique, maximum dose can be delivered to the tumor with minimum exit doses. So this is another modality. And in this paper by Delor et al., they have found with the use of carbon and proton ion radiation therapy, there's improved overall survival with minimum grade 3 side effects in the cases of locally advanced CA pancreas. So what if there is new tumor, new recurrences after radiation and chemotherapy? So then re-irradiation is another modality. So re-irradiation can be given post-conventional radiation therapy, where we have treated the patient with 25 fractions of radiation therapy, or post-SBRT also. So in both these studies, they have found that there is improvement in the symptoms of the patients, that is the pain especially, and there is increase in the overall survival from 8.5 to 14 months by the use of re-irradiation. So this is one of our patients in which we have treated by re-irradiation. So adjuvant radiation therapy was given in March 2020. There was a recurrence, and in this we can see that this is a high zone. So the entire area was treated with 45 grain, 25 fraction, but the SIB area was treated with 50 grain, 25 fraction, and the the recurrences which developed is there in the high targeted area only. So again, we have started with chemotherapy, and re-irradiation was done in March 22. So this is the follow-up scan after a year, suggesting of complete response at the primary site. CA pancreas patients, advanced CA pancreas patients sometimes present with pain. And to improve the quality of life, we need to improve the pain of the patients. So in this pain PANC trial, which is published in Red Journal this year only, It's a non-randomized trial of 30 patients with palliative RT therapy was given in 3 fractions over 3 weeks, 8 gray each, for the purpose of pain relief. So after radiation, there was a reduction in the median overall oral morphine level to 75 milligram from 130 milligram. The median overall survival in this group of patients was 12 months. The pain severity index was reduced from 6 to 3.2 at the end of 11 weeks, although there was slightly increase in the pain severity index, but as compared to the baseline, there was some relief in this group of patients. The global quality of life index was improved from 50 to 61 in this group of patients by the end of the 31 weeks, suggesting that the radiation therapy can be given for the palliative purpose as well. So in this, one of our patients, a 74 years old female, metastatic CA pancreas, large tumor. So we have treated this patient by a dose of 20 gray in 5 fractions, resulting in good local control, pain. So our experience: adjuvant radiation therapy in 17 patients, radical or consolidative radiation therapy in 9 patients, re-irradiation 1, palliative RT 4, and SBRT lung for the oligometastatic in case of CA pancreas 1 patient. In adjuvant radiation therapy, node positive were in 16 patients, margin positive 2 patients, PNI, LVI in 14 and 16 patients respectively. 2 patients were lost to follow-up. Recurrences or metastasis in 10 patients, local regional 3, simultaneously 2, and systematic recurrence in 5. The median overall survival in this group of patients is 38 months, and median progression-free survival after the completion of radiation therapy is 10 months. So the algorithm: in cases of CA pancreas with operable disease, surgery should be considered, followed by adjuvant chemoradiation therapy. For borderline resectable and inoperable, new adjuvant chemotherapy followed by radiation therapy, either SBRT or concurrent chemoradiation therapy, and surgery if possible. And for the metastatic, palliative radiation therapy can be used. To conclude, pancreatic cancer is a heterogeneous disease with a dismal prognosis. Implementation of multidisciplinary team approach prior to the initiation of any treatment. Radiation therapy has a role in all the stages. Participation in prospective clinical trials is the preferred option for all stages of disease. Thank you.